Right, I see Katie on YouTube. That's good news. I'm gonna hit record. Give everyone just a moment. Okay, welcome everybody to the December 14th, 2021 Community Advisory Group meeting. And I will start slides. As a reminder, we have interpretation in Spanish, so please use the globe at the bottom of the Zoom panel to select Spanish or English if you are listening in. And perhaps Maria or Laura could repeat that for me, please.
Bienvenidos a todos a nuestra reunión del 14 de diciembre del Consejo de Comunidad. Si hay servicios de interpretación en el español, si desea tener este servicio, por favor pulse el globo terráqueo al fondo de su pantalla para así oír la presentación en español.
Thank you. I'm going to start it now.
Oh, for some reason I don't see my interpretation
Button at the bottom. There should be a globe. Okay, we'll keep working on that. I just started it. And next is, as a reminder, we have closed captioning. So please click the closed caption controls at the top or bottom of your screen. And then finally, we have ASL interpretations, which is a reminder to our speakers and panelists to speak slowly for all of our interpreters. And for those of us who are joining via YouTube live stream, you'll only be able to see the ASL interpretation in the video. You won't be able to see the speaker unless you join us via Zoom. Finally, please feel free for our attendees who are not panelists to put questions in the Q&A, and we'll be happy to try our best to answer them in real time. And finally, for our panelists, we'd love to see your faces and hear your voices, but please mute unless it's your turn to chime in. Okay, with that, thank you. I will turn it over to, I believe, one of our co-chairs, Nestor.
Thank you, Lauren. Good evening, buenas noches. Welcome on behalf of myself, Nestor Castillo, Public Health Commissioner Greg Hodge, and Director Kimmy Watkins-Tart, who's actually on vacation at the moment, a well-deserved vacation. Thanks again for joining us this evening, especially on a cold evening in which there's a great basketball game on right now. I'd like to welcome any new members of this CAG to introduce themselves in the chat. And for those of us who aren't new, but are regulars to this space, why don't we do a little bit of a holiday icebreaker question? What's one thing that you're looking, we could be looking forward to many things, but let's name one thing that we're looking forward to this holiday season right in our chat box, please. And as we put in our one thing, I think the thing that I'm looking forward to more than anything is to be able to spend some time with my family, hopefully in a healthy and safe way. Let's take a second to look over the agenda. What we have planned for tonight, of course, is we're going to do, as always, our regular sort of partner updates. We'll do a little bit of the county updates and see where we are in terms of COVID. I'm sure folks are curious of where we are in terms of the new emerging variant, boosters, maybe some updates around masks and other things. So we're going to hear a little bit from the county around those updates. And then we will turn to a presentation around our EMS redesign. And that gives us an opportunity to provide a little bit of feedback, raise some questions that we may have, and have maybe a little bit of discussion there. And then we will close out, hopefully a little bit before 7 tonight. Does that sound okay with folks? I see a thumbs up, I see some head nodding. It's good to see folks on camera. Always great to see everyone's lovely face. All right, why don't we kick it off with some partner updates. I want to turn to our folks over at the Regional Pacific Islander Task Force. Who's going to be presenting from the Regional Pacific Islander Task Force tonight?
Good evening, everyone. This is Natalie Ossoon. I am one of the co-chairs of the Regional Pacific Islander Task Force. Tao Yuan. Oh, there she is. All right. So, good evening. Happy December, everyone. This month is going by super fast. So the task force was asked to provide a brief update on our work around COVID. Like many other small communities, underserved communities, we've had to resort to very unique approaches that are familiar to the community to reach our folks to make sure that they are healthy and safe during this pandemic. Oh, yes, let's see our PowerPoint.
So thank you, everyone. Thank you for the time, Lauren, that we have some more time. So what we wanted to do was really ground our audience in terms of how we want to approach tonight's presentation. And we really wanted to be intentional because we always talk about, okay, where's my... We always talk about, Pacific Islanders are very small population, and we are in small sizes. So there's a reason why we want to approach our work regionally. But I bet you many of you don't know how does that translate in terms of what is the number of population are we talking about? So we have a unique approach tonight. So that way we want to also use this opportunity to also educate our community leaders about who are Pacific Islander as far as what do we mean when we say we're a very small population. So we wanted to ground ourselves of really talking about when we say let's work with Pacific Islanders regionally, you'll see by the numbers that we have across the whole Bay Area. We do know that tonight is for Alameda County, but we are also mindful of that as well. So that's why we're very intentional about approaching our work and really educating our community leaders, not only our community, but also our faith leaders, and partnering with Pacific Islanders throughout the counties, specifically for Alameda County. So this is giving you a snapshot of where our Pacific Islanders in terms of the Bay Area. If you can see here, the largest population of Pacific Islanders is in Alameda County, and with 27,000 Pacific Islanders in this county. The total population in the Bay Area, which is the location that the work that Pacific Islanders, Regional Pacific Islander Task Force focuses on, is across the Bay Area of all 10 counties. So if you see all of these 10 counties here at a glance, these are the numbers we're talking about. So when we talk about disproportionate rates of death rate is where in COVID testing and what have you, and vaccination, these are what we're calling, these are where those numbers are at. And you'll see that there's gaps as Natalie go through some of our data. And the reason why we wanted to bring the data on a more granular approach and for you to look at is because we're one of the hardest to reach people. Not only that, but we have the highest death rate, since 2020. And with that, we still have a long way to go in getting our people vaccinated. And so community partnership is so important, because our community cross county lines to go to church and work and go to school, and all of the, we don't have homeless, communities. We go and live with families. So when you're isolated, you go across the county lines. I mean, there's all of these nuances that's happening within our community. So with that, I just wanted to kind of ground us on why are they showing the other datas and relevance to other county, is because you'll see the numbers of our COVID testing, the cases, and also the death. And so when we say we're all in it together and we're working together, this is what we're talking about, especially for a small population that has the highest rate of death rate, and it's growing with our community. And it's about, keeping our community alive. So I'll pivot over to Sister Natalie in letting you talk about our data.
All right, thank you, Tao. So the Bay Area represents roughly 30% of the state's Pacific Islander population, and 7 out of 10 Bay Area counties are currently reporting PI, Pacific Islander cases. We continue to work closely with Barhai and Bay Area counties about monitoring and reporting the Pacific Islander COVID cases. And this is a snapshot of our data dashboard, where the Pacific Islander case rate, the highest in San Francisco. And this case rate is, Pacific Islander numbers compared to calculated within its own population. And this image was updated today. So in these 3 counties, the Pacific Islander case rate is higher than the county case rate for all 3 counties that are shown on this chart. So we see Alameda County, San Mateo County, and San Francisco County here. I think the numbers are self-explanatory, and the charts here also showcases the Pacific Islander case rates, in comparison to the county case rates, and also showing that San Francisco with the highest. And here we see the death rates, which is also highest in San Francisco, and then Marin County and Sonoma County. Napa, Solano, Contra Costa, and Santa Cruz counties are currently not reporting Pacific Islander death data. Let's see this one. So here you see the death rates in orange are higher than the county death rates for Pacific Islanders in all 3 counties. So among these 3 counties, the Pacific Islander death rates are very high. Next. And here, the highest number of Pacific Islander vaccinated are in Alameda County and Santa Cruz County, and lowest in Santa Cruz. So these are in the total in California among Pacific Islanders is nearly 150,000. In the Bay Area numbers are in the 6 million count. And then the Bay Area total for Pacific Islanders who are vaccinated are at 41,000 plus.
And just to add with Natalie, the data here, so from our demographic report, if we're looking at the California overall, there's a total of 140,788 Pacific Islanders in California, but for the Bay Area, that's your number that you see for our Bay Area Pacific Islanders, which was, I think we said earlier, is about like 90,000, amount, the population of our Pacific Island here. So if you look at the vaccinated of 41,107, folks. There's still a lot of unvaccinated Pacific Islander across the Bay Area that we still have not been able to reach.
And here, so the Pacific Islander Task Force, we created our own dashboard to collect and monitor the data among Pacific Islanders, and the data we do retrieve them from the data dashboards of each of the counties. And every week, our team of students and researchers are pooling this data and reporting these out. Okay, next. So as you can see here, these are our vaccination data, quite high. Some of the counties are, as some folks are asking, how come the data looks like this way? Over 100% of the vaccinated among Pacific Islanders. So there is highlights the extreme high rates of vaccination among Pacific Islanders. There, as you all know, you all work for the county on data collection and reporting. The data does not always tell the story of how diseases and illnesses are impacting our communities. Some of the data collection are not reliable. We also know demographic data are not always completed, are not reported as we want them to be. So the data is not as reliable as we all want them to be. Unreliable in terms of population denominator estimates, more individuals reporting Pacific Islander identity during vaccination than in the denominator, issues with the reporting system, and so forth. And we actually think that the counties with over 100% are particularly inaccurate because it reflects a denominator issue with the data, since many more people are reporting as Pacific Islander than accounted for in a population estimates in the census data and from the Department of Finance estimates. And although these numbers are not as accurate, we hope that the dashboard information can still be used to help inform and help with community outreach efforts.
So with that,
on to you.
Okay. So with that, we can give you all the photos and all the information of the work that we have been doing throughout the year and since day one. First of all, the data that you have seen, but the county that has really improved on all of the vaccination, the COVID testing, reporting the data, is Alameda County, and we were very intentional of bringing that to you at a glance. This is a continuation of the systems inequities, especially for the data disaggregation between the Asian and Pacific Islander. The task force is able to do our own advocacy with partners like Barhai and partners like the Alameda County and the partners that we have here. It is important for us to really lift the voices of disaggregating our data. It's already signed in law, and we are still aggregated with Asian communities. So for our vaccine, the community outreach that we have been doing since May of 2020, we have distributed over 18,000 food boxes to our Pacific Islander communities. Sometimes we have to do what we have to do to feed our community. And some of the partners on these calls are saying, hey, as long as you feed your community, that's all that matters. As you can see, the numbers are just, it doesn't fit, for us to be able to get any funding if we have to go through the county. So we totally understand that. But the work that has been done, we continue to do those work, especially with our county partners, as well as our partners that we have. the other things that we have been doing is, COVID testing, and we really want to give a shout out to our partner CORE with the testing. They've been with us since day one to do COVID testing every Fridays and Saturdays at our San Lorenzo Community Church since June of 2020. And, I also want to just give shout out, again to Alameda County for continuing to trust in us. We may be small, but, we definitely are self-determined. We're determined to make sure that we continue to educate you, to helping us. And I also want to give shout out for partners like Asian Health Services, has been there with us since also day one. And since the vaccination and COVID testing, big kudos and a big shout out to Brother Aaron with La Familia, and also Glad Tidings. They've been such great partners. Just recently, we couldn't find, enough partners to do our clinic. Vaccination clinic, and La Familia, stepped up and said, we're going to help you. And so, again, we can go on about all the work that we have done, but one thing that raised out of all of this work, we can't give up, because when we talk about, we are all in this together. We too, as a community, have to educate, like, how do we do that though? Since you're hard to find community, hard to reach. So what we want to do is, we want to just say, continue to work with Pacific Islanders. And we are in all of the counties. We're also in your neighborhoods. So rather than just a task force, there are faith-based organizations, so they might be in your neighborhood. When you hear them singing on Sundays, yep, that's either our Tongan community or Samoan community. Reach out to them when we do a lot of this COVID outreach, and whatever you do, just reach out. And if you did, thank you so much. We can't do it alone, and we know that, we witnessed that throughout this pandemic. So we just want to thank you in advance for those that continue to believe in this work. I think coalition comes, so up there, and then we need to amplify that. We need to work collectively in coalition. So partner with us, and we can always, we'll always be here to, to help you, help us. But, I hope that was insightful. I hope that was helpful. What Natalie and I wanted to do was really be intentional on the way we wanted to approach you tonight, because you don't know what you don't know. So because of the small population that we are, I think we owe you some education as far as, our numbers across the Bay Area. And that is why it's very difficult to reach people like us, our community. So with that, I just want to say thank you, everyone in this panel. Thank you, Greg and the team, and Nestor, and all of you, and Sister Lauren. Thank you for all that you do. She's always nudging us, and we say, but most of all, I just want to thank you, my sister Natalie. As co-chairs, it's a lot of work. So, and we barely making it to this meeting today. She's coming from 3 meetings, San Francisco, hitting traffic, getting to Hayward, and then I'm just like, we cry, on our own, but we just want to say thank you so much for the time. And with that, thank you.
Thank you, Tao, and thank you, Natalie, for that very informative presentation. And thank you for all of the work that you do for your community and for our collective community as well. I'm sure that you can please continue to let us know what you all need in terms of support. I think you outlined it well, of how we can continue supporting. I think we have time for at least a question if folks have questions, or at least maybe one more partner update if folks have any announcements or any updates they'd like to share.
Aaron Ortiz with La Familia. I just want to let the team know that we're going to have Vaccines with Santa next week on Tuesday. So just wanted to let everyone know. We'll be sending out flyers. So Vaccines with Santa, you get vaccines and a picture with Santa if you want it after the vaccine. Thank you.
Thank you, Aaron. And what was the date of that event again?
21st.
21st. All right. So if you want your picture with Santa, go and are you all offering boosters as well? This might be a good chance to get your booster and get a picture with Santa.
Yes, boosters, third shots, and definitely the key will be to vaccinate the young people that qualify. So thank you for asking that.
Does that mean Santa's been vaccinated?
I think so. I think it's official. I would have to ask my team, Tao and Natalie, with nothing but love and respect.
Just double checking. I know
If they
Big
say
Bird
yes,
got it.
then I'm good.
And
Big
maybe
Bird's
the
been
reindeer as well.
vaccinated. It was a deal.
Any other announcements or questions for our presenters? Mary Lou, I see your hand.
Yes, thanks, Greg. I just wanted to let everybody know that Disability Rights Education Defense Fund hosted a webinar on COVID vaccines for kids with disabilities. The webinar was with Dr. Noemi Spinoza, who is with UCSF, Benioff Children's Hospital in Oakland. If you're interested in taking a look at that webinar or sharing it with families or parents who might have questions about the vaccines for kids with disabilities, I posted the link in the chat, sort of up at the top. Happy to post it again if people would like that. But that's it for me. Thank you.
Thank you, Mary Lou. All right. Any last announcements that we want to share or questions for our presenters before we move on to our county update? Going once, going twice. All right, let's switch over now to our folks over at the county. I think Donata is going to be facilitating this portion of our meeting. So I'll turn it over to you, Donata.
All right, thank you so much, Nestor, and good evening, everyone. So for this section, Dr. Moss will share the county updates today, and then we'll switch over to Tueri Anderson, who will share updates on our hyper-local vaccine campaign. And then Nick and I will finish up with just talking a little bit about what's next and what we can expect and when are we at the finish line with this COVID pandemic. So with that, I'm going to turn it over to you, Nick.
Thanks, Donata. Good evening, everyone. Good to be here. Really glad Kimmy is not here and getting a well-deserved break. First, just some high points. Our case rate is up a bit in Alameda County, just a bit. Things are, I would say, it's not clearly winter wave territory yet, and they may settle out again, but we've certainly seen some increases. And test positivity went up and then it went back down again. What happened was testing numbers went down over the Thanksgiving holiday, and they've really recovered. We're back to getting a lot of testing done on a daily basis across the county. Hospitalizations also bumped up a bit, although they've come down over the last few days. And of course, the national picture is people are seeing winter increases. This is really all still Delta variant, although that information on sequencing, that there's a bit of a lag there. So we'll talk more about the new variant in a minute, but the big story is nationally increase in Delta cases. California maybe starting to see some increases. Again, it's a little confusing because everything really went down during Thanksgiving while people were off, while people were celebrating the holiday, excuse me. Next slide, please. And this is just an illustration. If you actually look at the reported cases, this is from a few days ago, but I can tell you the story is still the same. We are not yet seeing dramatic increases, still kind of bouncing around a bit. Next slide. And this is the national picture, and you can see the last few weeks on the far right there, with the exception of the notch during Thanksgiving, pretty steady increase across the country in reported COVID cases. Next slide, please. So what about this variant that everybody's been talking about? The Omicron variant, it appears to infect. So this has been described now in a few places, and it's been shown to when you are able to look at data on either the sequence of cases detected or similar signals in your testing results, you can see Omicron spreading pretty rapidly in a few places in a few different parts of the world now. Even Washington State has seen this in some of their testing data. This variant really first came to light only a few weeks ago, but there are several concerning things about it. So first of all, those rapid increases in cases, a collection of mutations in the virus that suggests that it may be better at avoiding our immune responses, including immune responses from natural infection and also immune responses from vaccination. And these things together have quickly elevated this to the newest variant of concern and something that people are following very closely. The early data does appear to show that it infects previously infected people. So this idea that you're protected against COVID infection if you've already had COVID, that may not be the case with this variant. It does appear to cause more frequent reinfections. And then similarly, vaccinated people do appear to get infected with this. The vaccine effectiveness against infection is decreased pretty dramatically in some studies and with some vaccines, although it's still early. We're still learning. I would say this is an area where we're going to learn even more in the next few weeks. Booster doses do appear to improve protection, so to reduce the chance that you'll get infected at all. And so that's encouraging. It is not yet known how much severe disease Omicron will cause. There's some early reports, mainly in the media, that it may cause more mild infection, but in my opinion, it's really too early to make this call. You really have to think about what populations are being infected, how old people are who are being infected, and you really need enough time to have gone by for some of those severe infections to happen and then get detected. And that, as we all know, can take several weeks with COVID for people to get severe disease once they've been infected. So I think it's just too soon to know. And as part of that, it's too soon to know if vaccines and boosters will prevent severe disease. There's, again, a little bit of early evidence to suggest that vaccines will continue to prevent severe disease. I know some experts think that that'll be the case. I'm hopeful that that'll be the case, but we don't really know for sure yet. I think it's a fair bet that Omicron will spread widely in the United States, given what we've seen so far. Even if it causes mild infection, if it spreads widely enough, it's a very, very transmissible virus. It's winter. We're talking about potentially spreading among vaccinated and previously infected people. So even if it causes mild disease, it's going to infect so many people that there is still a potential for overwhelming our healthcare system. Whether that happens in Alameda County, I think is really comes down to how well the vaccines hold up in preventing severe disease. But nationwide, I do think we're setting up for a potentially difficult winter. I think it's just important for people to be aware of that. Again, this really hasn't taken off in most parts of the US yet, but And even though we've had some reported cases here in Alameda County, they're actually, they were acquired out of state, and we have not yet documented any local transmission. It is only a matter of time. That is going to happen. It may already be happening to a small extent, but we just haven't seen it yet. Next slide. Again, you've heard vaccine maybe not as good at preventing infection, but maybe still holding up against severe disease. And certainly, I think we're expecting that. Fortunately, we are continuing to make progress on our vaccinations. So we changed the dashboard around, I think, since the last call. Now, what we show is when you click on the percentage, it's the percentage of the total county population that's vaccinated, not just age eligible. So when you look at the whole population of the county, 78% of people have received their primary vaccine series, which is terrific. And it continues to increase. The most recently eligible group, the 5 to 11-year-olds, over 40% of them have received their first dose of vaccine, and you have to really squint your eyes to see the small type. But I think about 25% are fully vaccinated. So again, that's good news. We've had people quickly embracing this. It may slow down going into the holidays. The early adopters have already been vaccinated. We should be prepared for that. But nevertheless, overall progress is good. Next slide. Similarly with boosters, making fair progress here. So about 450,000 county residents have received a booster. That's about 35% of all who are fully vaccinated. But remember, for most people, you have to be 6 months out before you can get a booster. So a lot of people haven't hit that 6-month mark. If you just look at people, how many people were vaccinated who've reached that 6-month mark, we're closer to about 50%. We vaccinated about 50%. So still some work to do in terms of getting people to boosters. I know appointments have been hard to come by for some. I just scheduled my booster appointment today. I decided to stop putting it off. I had to hunt around a little bit, but I got something for next week. So, and I've looked at the drugstores too. You can do it. I encourage people just to have a little persistence, get those boosters scheduled. We're doing better with the older age group. That's the group where we're most concerned about breakthrough infections causing severe disease. So that's good. Next slide. In terms of the parts of the county where we still have lots of unvaccinated people, I think this should be familiar to anybody who's participated in these meetings for some time. Same places that in the earlier stages in the vaccine campaign, adoption was a little bit slower, and we were working hard to answer people's questions, improve access, things like that. And in fact, vaccination numbers have gone up just about everywhere. We still have some patches in our priority neighborhoods. Along that 880 corridor, as we sometimes call it, the most densely housed parts of the county, lower income parts of the county. So I think this argues for why we need to continue our efforts to reach into those communities, make sure people have access, get their questions answered, get their primary vaccination series. Next slide. Last week, the FDA authorized, CDC recommended, and also the California Department of Public Health recommended booster doses for people 16 and 17 years old. So this was previously it was 18 and up. Now it's 16 and up. For everybody 16 and up who's had enough time from their vaccination can get a booster. And we strongly recommend that people get boosters because with winter coming, Omicron coming, we want to get as much protection in our communities as possible against severe disease. And if they do, boosters do help reduce the risk of infection. That's going to really put a dent in any winter wave here. That's why I signed up for mine today. I just, got to practice what I preach. Next slide. So the other big news this week, the state has issued a new statewide masking requirement for everybody in indoor public spaces, regardless of whether or not you're vaccinated. Some of you may recall that we already have this in place here in Alameda County. It's been in place since August. Much of the Bay Area has a similar requirement. Essentially, the state took this approach statewide because of concerns about the coming winter and the Omicron variant, wanting to protect communities, including parts of California where vaccination rates are lower. Just this afternoon, they indicated that counties that already had this requirement in place could keep doing what they're doing. So we are just still looking at the language of this, making sure we're talking internally about exactly what that means. But for the time being, there's no real changes to policy here in Alameda County, and we will hope to make a public statement relatively soon about this. Next slide, please. A couple other policy updates just to be aware of. The state does have some recommendations and requirements for large events, mega events they call them. They just tweaked the testing timelines for those. So if you're going to an indoor event and you're not vaccinated, there's more than 1,000 people expected, you have to test within 2 days with a PCR test or within 1 day if it's an antigen test of that event. If it's an outdoor event and it's going to be more than 10,000 people, you're recommended to test, but it's not required. And again, similar timeframes. The other thing the state did is issue a new travel advisory. They're really pointing to the CDC's travel guidance, practical advice. There are some specific restrictions around international travel people should be aware of. But what the state also did is recommend, not require, but recommend anybody traveling into California, whether you're returning home or you're just arriving, anybody traveling into California from other states or countries should test 3 to 5 days after arrival. Next slide, please. We covered a lot of stuff in a relatively short time. Omicron, new mask guidance, boosters, all that. I want to tell you what our messages are for the whole community for staying safe this winter. And you will see that this message really hasn't changed much from what we've been talking about all along. Get vaccinated, get a booster as soon as you're due, wear masks indoors, stay home when sick, avoid those crowded, poorly ventilated indoor settings. We know that's a place where COVID can spread easy. Of course, wash your hands, test before and after travel and holiday gatherings, and just to be aware of all those travel rules. And I think that's my last slide in this section. Yes.
All right, thanks, Nick. And now we're on to Tueri's update.
Thank you, Donata. Thanks, Nick. Good evening, everybody. It's nice to be here with you all on this chilly December. I'll just give you a brief update on the HCSA Hyperlocal Vaccination Media Campaign. So just as a reminder, you can go to the next slide, please. Just as a reminder and to pick up from what Dr. Moss just said, that there are many messages, the evergreen messages for really staying healthy this winter, and that this hyperlocal vaccination campaign is specifically focused on vaccination. So in our other communications and social media streams, we are talking about some of those things that Dr. Moss spoke to: washing your hands, masking, boosters, etc. But just in case the question does arise, this is specifically focused on vaccination and primarily reaching out to folks who have not received vaccinations, who might be on the fence, or who have not completed their vaccination series. So just an update, the campaign is really, it's data-driven, both qualitative and quantitatively, informed by all of our different community partners, including people around this table. And this is a primarily digitally focused campaign. I'll get into it a little bit more in some of the later slides. And it is a very focused and targeted campaign that will not be broadly seen by everybody. So I just want folks to bear that in mind. And what you see on the left here is some of the updated creative that we have been running on digital streaming. Next slide, please. Just a reminder that this is our iterative feedback loop for this campaign. So myself or any of my colleagues in HCSA communications may be going to different community groups and some of our other colleagues, just continually getting feedback. What are you hearing? And making sure that that's informing our campaign iteration. The beauty of digital, of course, is that we can change the creative pretty quickly. So we're constantly learning, basically, in making this as relevant to the time as possible. Next slide, please. Okay, so these are sample digital banners that we have been running for the last couple of weeks, and we have settled on 2 different campaigns. This one is a Counting on You focus that's really about community, family, and eliciting more of an emotional response to potentially motivate people to get vaccinated. And you'll see that it's really about counting on you, people waiting for loved ones to get vaccinated to resume connection. Next slide, please. And the second campaign that we're running is Keep It Real, which is our sort of myth-buster campaign, giving factual information and saying, hey, here's the facts. You decide what you want to do with that information. And again, here's some examples of creative. This isn't everything, but you can kind of get a sense of what this is looking like for the digital banners. Next slide, please. Okay, so this is where we are this week. Just a reminder that where we got to with this creative was after over 60 people who provided feedback into our initial drafts of the creative. Thus far, we have garnered over 4 million impressions and almost 5,000 click-throughs to the vaccination sign-up page here in Alameda County, with a click-through rate of 0.11, which is really, that's above industry standards. I'm not the communications professional, but I do know that oftentimes click-through rates are looking at 0.02 or 0.04. So something that like 0.11 is actually pretty successful. And the campaign is on track to get 18 million impressions by the end of January. So social media, it's in progress. Some of those banners that you saw are running on Facebook and Instagram. And as we speak, our streaming audio scripts are being finalized and being recorded this week. And we anticipate that it'll generate about 1.3 million impressions. Streaming audio services like Pandora and Spotify, these kinds of things. We are looking at in-language media with over 10 hyper-targeted publications that will launch this week and more next week, looking at almost 7 million impressions. And we do have billboards. So these will be the static ones. These are not digital billboards. And that will launch next week. It's really exciting. We looked at the creative today in one of our operations meetings that are launching across the county in priority neighborhoods. One is in Chinese and one is in Spanish, and the others are in English. And next up, sorry, I just got a pop-up since blocking my slide. Next up is the Spanish language TV and other targeted TV streaming services to launch after Christmas. Okay, next slide, please. Okay, I guess that's it. I don't know if folks have any questions before we move on, but I'm happy to answer any questions.
All right, thank you so much, Tori. Go ahead, Nestor.
I'm sorry, Donata. This is Greg. Yeah, we can open this up for questions on any of the reports that just came out, the data, Omicron boosters, the hyper-technical vaccine campaign. Yeah, very good. Any comments, questions? There may be one in the chat. Let's see. This is from Pastor Arlene. Is there any guidance about attendance limits for indoor events? Like back during SIP, there was a recommendation to limit attendance to 25 or fewer. Any comments on that?
Yeah, so we haven't, neither us nor the state have introduced any kind of limits to the number of people in indoor spaces. I think, we certainly have no plans on doing that. I don't think the state plans on doing it. We'll see what things look like in a few weeks. But we are recommending again, avoiding crowded indoor settings. And so to the extent that I think people want to, plan accordingly, have smaller groups indoors, I think that is a perfectly reasonable thing to do this winter, in particular in settings where masks are going to come off at all, and in settings where you might have people at higher risk for worse outcomes.
Cool. Thanks for that, Nick. I have one question myself actually about boosters. So let's say you get your booster now because you were eligible for one. Is it like annually? Is it every 6 months? Like, what's the timing of the next round of boosters?
Yeah, that's a good question. I don't know the answer, and I think it's going to depend on what we are actually trying to get out of the boosters, and how quickly, over time, if we see fewer and fewer variants emerge because more people around the world have had the opportunity to get vaccinated, or that's could take a while, but eventually, hopefully, that'll help. So I think it is possible that we will need COVID boosters in the future. I don't know if that's an every year thing, or if it's once in a while, or if somebody comes up with a vaccine that has sort of, that's sort of variant proof. Or it may turn out that, we end up pretty well protected against severe disease over the next, 12 months, and that we just watch and see how things go. But if I were to put my money on something, I would say it's going to be something like annual boosters, at least for the time being. Probably not forever, but for the next few years.
Okay. So, and this kind of leads to one other question, and this is on everybody's agenda, where we kind of, I guess, rhetorically ask the question, what is the finish line and what do we need to do to reach it? So, finish line.
Yeah, I think we have some slides on that. Okay. But before I go, just also, if anybody else has more insights into the future of boosters question, I know there's some other people on the call who might know. Feel free to chime in. That's sort of speculative.
Okay.
Yeah, this is Noha. Hi, everyone. I agree. We're speculating. I think some of it may depend on whether we're looking at one variant displacing another, or whether we're sort of dealing with multiple variants, because I think then it could become sort of like flu, where it's sort of every year you're sort of targeting, one or more variants. I think there's still a lot of question marks out there. But I think for the foreseeable future, I think we would, and I also think that this sort of third dose that we're doing now may not be considered or called a booster. We may be redefining what the primary series is. So if this becomes like a vaccine that everyone gets when they're a baby, it may be like, this is a 3-dose series, like many of our other vaccines. So I also think some of the naming is tripping us up a little bit. I'm sort of starting to lean myself toward just saying third dose, assuming that we might have to go to 4th dose. Understanding that there's some nuances within that, but I think, at this point, it's like, one step at a time.
Cool. Thank you for that. Other comments, questions, observations, and then you said there are some additional slides on this.
Yeah, we just had a couple of slides just to talk a little bit more about the finish line and what we're doing now. And Dr. Moss already covered a little bit of that, but we can just spend maybe 5 more minutes on that.
Sure, please.
All right. If you can go to the next slide, please. All right. So really, we wanted to just talk a little bit about where do we go from here, and really, is there a finish line, and what does that look like? And as I mentioned, Dr. Moss already talked a little bit about that. But really, what are we doing right now? So this, Dr. Moss mentioned the new statewide masking requirement and some other policies that the state is putting out. So that hopefully will buy us some time and curb immediate surges that we may see, but we are still expecting a winter surge. But that will really give us an opportunity to vaccinate those people that are still unvaccinated, and for our youth to catch up, and also to get people their booster shots, which we're working really hard on right now. In the meantime, of course, we want to continue messaging and making sure that everyone understands the importance of vaccinations. So working with our community navigators, as well as with all of you, to share that message. And the great work that Tueri shared with us about the hyperlocal vaccine media work that's going on. So hopefully we'll get some more folks vaccinated that way as well. Right now, our COVID division is continuing to train additional staff and are prepared to continue the response work. So we're not slowing down. Our COVID division operations have started some integration back with our acute communicable disease unit and our immunization program. So we may have mentioned before that our immunization program is helping us co-locate flu vaccinations with our COVID operations. We've also been sharing staff, training, and coordinating very closely together. For example, our case investigation team works very closely with our outbreak team. So that's some indication of moving towards back to our normal operations, but it'll take some time. And we're also getting very excited about our new coalitions coming on board in the new year. So that will expand some of our health education efforts, also enhance culturally targeted community education, as just increasing our language capacity, as well as helping us with consistent and persistent messaging. And again, it's an extension of our public health efforts. So we're really looking forward to that partnership. And then just keeping our communities up to date on new and emerging health information, and again, working on messaging together with all of you. On the next two slides, Nick is going to talk a little bit more about what we can expect, and then I'll wrap it up with the final slide.
Yeah, and so I think I covered some of this, but again, prepare for a winter wave, possible hospital surge. I don't think it'll be as bad as what we have seen here last winter, but hard to know for sure until we have a little more information. Again, the comments about Omicron there, and I can't stress this enough. If you're due to get boosted, don't wait, get that booster. I think it's probably one of the most important things we can do besides keep our masks on right now. Next slide. So, and we've kind of touched on this as well, but we should not be looking for a clear finish line. Not only will COVID not go away, but I don't think there's going to be this point where we sort of say, mission accomplished, the pandemic's over, now it's everyday life. I think it's going to be this much more gradual process that we've already been in, really, that started like in April of 2020. After the initial shelter in place orders began to be sort of modified and slowly trimmed back. And I think that process is just going to keep continuing until COVID really is more like the flu in terms of causing seasonal community spread, outbreaks certainly, but with severe disease less common, except in higher risk groups, and maybe those will look the same as they are now. Maybe that'll change a little bit. There'll be more and more access to treatments that should be able to help people who are sick avoid the worst outcomes. But as we were talking about, I think vaccine and boosters are going to be with us for some time as the mainstay of prevention. And remember, every year a new group of human beings gets added to the population that don't really have much immunity to anything. So there'll be, at minimum, I think, the need to sort of ensure some prevention with young children and potentially ongoing boosters for all of us in some way. And then I think, masking requirements, even though we have a lot of masking requirements right now, those are not going to be with us forever. But maybe some of the masking habits will stay with us. I think one thing that's really characterized, I've got a chance to listen into detail about lots of outbreaks and exposures that aren't outbreaks and things like that. And I think everybody knows this from their life, but it's hard to stay home when you're sick. And some of us are really good at it. Some of us never do it. And there's everything in between, even when there's a global respiratory virus pandemic. And so, maybe, we'll at least get people who are leaving the house when they have a sniffle will be wearing masks more than they used to. We'll see. With luck, we don't have to do anything like these legal requirements for COVID in the future. Regardless of what it looks like, I think there's going to be a continued need for public health interventions. Certainly, we're all preparing to work with you all to help prevent the spread of COVID. I think for now it's indefinitely. And then I think Donata is going to take over and talk a little bit more about possible shape for that.
All right, thanks, Nick. And for the last slide, I just wanted to talk a little bit more about, after the winter surge, we're already thinking about how we can start slowly shrinking the large COVID division that we have. We do anticipate an ongoing COVID response team within the acute communicable disease unit, which is within public health. Our focus will probably shift from individual case investigations and contact tracing, which we're still doing quite a bit of right now, rightfully so, but we will probably start focusing more on managing outbreaks and also focusing on complex cases and sensitive settings like our shelters and our skilled nursing facilities. Our vaccination efforts, like many of you have said, and Dr. Moss has mentioned, we may need to continue getting boosters, but more to come really on that. And so in the spring, we anticipate shifting more from a response mode into some kind of a recovery mode and ongoing community engagement to remain really vigilant and aware of any new developments. So really keeping all of you informed about what's coming and what's going on. So there's more to come. We'll learn more about Omicron in the near future and continue to work on increasing our vaccination rates. So we'll keep you posted. And that's the end for us, but welcome for any questions, if there are any.
Thank you. Let me ask Dr. Bruce, did you have a question a little bit earlier or a comment? Because we thought maybe we saw your hand go up.
Yeah, I did have one comment. You have all of the information going out to the public, and one of the numbers that you put down is 18.2. And psychologically, putting a 0.2 raises more questions in people's minds. What does the 0.2 mean? And I know that's what the public has as far as the county and everything, as far as their information. But a clean number is less questionable than a number with a point on it, with a percentage. So it's over 18%.
Yeah,
that's just a suggestion.
No, that's great, Dr. Bruce. And I think you were talking about possibly the creative that you saw, because that point actually did come up when we ran some things through the Emoja Youth Health Mobilizers, and they're like, don't do that. It's not helpful. So we're right on target. Thank you.
They're not having exact numbers either, because people, I get asked practically every day about from various people, and where do you get these numbers from? And like you gave the 100,000, et cetera, for numbers of people together. And even though they're at a big distance place, I can't figure out how they could say, well, it's not as dangerous if you're more clumped together, breathing each other's breaths and having them cough on you than if there are less people in that area. Just thinking about the logic on that doesn't sound logical. You should protect yourself, period.
Right. Cool. Thank you for that. Any other comments or questions before we go to this last agenda item for the evening? Anybody?
I just wanted to say thank you to Tao and to Natalie for uplifting the Pacific Islander community. Thank you. Always. Y'all are powerhouses in the work that you do.
Absolutely. Absolutely. All right. Let me turn this over to our good friend Anika Chaudhry for the Emergency Medical System Redesign conversation. Hi, Anika.
Hi, everyone. Good to see you again. And Greg, just so you know, that is Zora screaming right on cue, if you can hear her in the back.
I would be disappointed if it were otherwise.
Exactly. So thank you all for making some space on your agenda today. I'm actually here with Lori McFadden, who is our Director of Emergency Medical Services. And that's another function that our agency holds. And so, while it's interesting, we're talking about sort of this long emergency we've had with COVID, but then there's obviously everyday emergencies. And so our EMS system is pretty big. And one of the things that we are doing is every few years we RFP out for a new system provider. But the EMS agency has undertaken sort of a year-long system redesign process. And we are gathering feedback from community members. And so we really value the feedback that this table always provides. And if you have thoughts on what you hear today or other spaces where we might want to go to get feedback from the community, we would be really interested in that. And there will also be other opportunities. So we're thinking of doing some broader community forums in the new year, also to get some feedback on this. But so I will turn it over to Lori so she can walk through the slides. Thanks.
Thanks so much, Anika, and thank you to all of you for allowing kind of a little bit of a left turn in this presentation. But COVID really has given us a lot of lessons learned, and I'd like to just go ahead and share a brief presentation that I'll have. This in presentation mode. So are you able to see the actual slide?
Not yet.
Not yet. All right. How about now?
Nope.
Oh, delightful.
Laura, if you want me to run them, let me know.
Go ahead and do it.
Okay,
Thanks.
let me do that quick. Let me open it now. All right.
It's always something.
Yeah.
Usually it's me. So.
Awesome. Thank you, Tueri. So I just, again, want to say thank you for giving me a little bit of time. With everything that's gone on, we actually started our system redesign in 2019, right after Falk took over the ambulance contract. And COVID gave us a little bit of a curve. So it's taken us a couple of years to get through this process, but we're not done, because now we're getting to the fun part where we want to get the feedback from our community. Next slide, please. And so why are we here? Why do we come to you? Next. So we want to be sure that we have equitable access, fiscal responsibility, appropriate destination for all patients. I'll get back to that later, and sustainability for our system. And so now is our chance to make our EMS system better. We need community feedback to accomplish that. And if we've learned nothing else from COVID, it's about all of us doing these programs. And so we have user experience, system partner feedback, and technical regulatory requirements that inform the system redesign. So this is part of a large, robust session of brain children coming together to do the next system. Next query. So what is EMS? When I tell people that I'm the Emergency Medical Services Director, they go, oh, so what do we do? So we're a division of the Healthcare Services Agency, but we're also a state designated local emergency medical services agency, LEMSA for short. That is, we have regulatory business in Title 22 and in the Health and Safety Code. So we have a lot of regulations that we uphold. Next, please. And so the oversight that we are in charge of is personnel and training. So that's for EMS personnel, that's paramedics and EMTs. Communications, that includes dispatch. That includes the radios that we use and all of the different communication modes. Ambulance transportation, assessments of hospitals and critical care centers. That means the stroke care that you get, the trauma care if you have a terrible accident, or if you have a heart attack. Then we have system organization and management, and that's what we're doing right now, is we develop a whole system to get to emergencies in our community. We do data collection, we do extensive data collection, and we've been working with a lot of the partners on this call to use that more intelligently and widely. And we use that for system evaluation as well. We do public information and education. In fact, Falck has some ambulances rolling around right now that have our artwork on them that talk about strokes and stop the bleed and signs and symptoms of heart attacks. And we're also heavily involved in disaster medical response. In fact, in the COVID response, thanks to emergency medical services providers and partners, we were able to keep all of our skilled nursing facilities open during the hardest hit time. And we had often EMTs, paramedics, and nurses from the ambulance providers staffing those facilities. Next, please. And this is our EMS system by the numbers. We have 5 911 ambulance transport operating areas. So that we have the City of Albany, City of Berkeley, Piedmont, Alameda. The fire departments give the ambulance transport there, and the rest of the county is Falck. We have 6 fire and EMS dispatch centers, 10 fire departments, and they are our first responder advanced life support. So you may have maybe called 911 and a fire truck got there first. All of our fire engines have paramedics on them, and there are more of them around so they can get to you faster. And then the ambulance will follow up and they'll have paramedic on it as well. But first responders are very important in our system, and that's our 10 fire departments. We have 14 interfacility ambulance providers, and those are non-emergency ambulances. So that's allowing a hospital to transport someone who isn't able to go in a car from the hospital back to, say, their skilled nursing facility or a rehabilitation hospital or even home. And then we have 15 911 receiving facilities. We have 3 trauma centers, 7 STEMI centers, and STEMI is just a certain kind of heart attack, 8 stroke centers, and 2 behavioral health facilities. And there are 160,000 calls for service per year for ambulances. And 50% of our volume is in Oakland alone. Next, please. So for the past several decades, we've had private transport providers. So we had AMR, and then Paramedics Plus and Falck. And they've all done their best to deliver services here. But one of the things that we're seeing now is the cost of the services going up while the reimbursement is going down. So they have a hard time making ends meet and getting their service delivery. And COVID has thrown different challenges at them. So we're seeing a lot of different things in our system that we haven't seen before. Next, please. So these are the biggest challenges facing the EMS system. Addressing community needs. So we want to make sure, again, equitable access, the system structure, the payer mix, and how the ambulance provider, whoever they are paid. Hospital saturation. Right now with COVID and staffing, our hospitals get full and our ambulance providers are waiting in the hospital, waiting to give their patient turnover care to the nurses and doctors at the hospitals. I've already mentioned that staffing is a big problem. Financial stability for any provider is difficult right now. And right now we only have one pathway model. And we're at a crossroads. EMS is at a crossroads. And so Alameda County is known in the state for being innovative, and we plan on doing just that. We're looking to you to be innovative, and all of you have the power to help us do that. Next, please. So this is our current ambulance response. 911 is called by a citizen, and the call is answered and triaged by dispatch, and then an available ambulance is sent to the call, and then perhaps that patient is transported to the hospital, and then patient care will be transferred to the hospital's care. And one of the things about this is, in a lot of cases, people don't need to go to the emergency room. And I don't know if any of y'all have been to an emergency room, but those are not inexpensive. I remember going to the emergency room for a broken collarbone and was shocked at how much I paid for that emergency room visit. So this is the path for the 911 ambulance right now, both through regulation and because of payer information, you know, with Medicare and Medi-Cal and some of the private providers. And this is also driven by response times. So it tries to be one size fits all, and that's not always the best thing for our community. And if you ever are interested in looking at some of our stats, there is actually a hyperlink that's on this slide where you can go look at our response times and look at our hospital wait times, how long our ambulances are waiting at the hospitals. Next slide, please. But this is the meat of what I want to talk about today. This is our dream. This is our envisioned system. So we want to stop people from going to the hospital, period. We want to do call prevention through community education and community paramedicine. And some of you may be familiar with Assembly Bill 1544. It is going to allow, through legislation, alternate destination and community paramedicine. And I'll give you a couple examples of what community paramedicine might look like in a minute. So then what happens if, you know, when somebody does need to call 911, citizen will call and it will again be answered by dispatch as usual. But this time there's a choice. So the first mode would be what we have before. An available resources sent for transport, but maybe not to the hospital. Maybe they take them to a crisis stabilization unit, or they give them a referral to the Firehouse Clinic in Hayward, or to a different clinic in a different area, or to a healthcare provider or a medical home. So there's a lot of different ways that this could go. And then the next thing, we want to have a clinician in the dispatch center so that they can go through and triage. I'm sorry, was someone asking a question?
No, my apologies. I came off mute accidentally.
Okay. And so then we want to have a clinician in the dispatch center so that they can talk to the person who's calling to see if really it's a life-threatening issue. And if it's not, then they can give them some guidance along the lines, if some of you are Kaiser members, like the advice nurse, they could give a referral or give them connections to other resources. And then another option that we're thinking about is telemedicine. We found that that worked very well. And I know that some of you in clinics also moved to telemedicine. And they can give guidance that way and referrals, and again, connection to resources. And then with the community paramedicine, we talked about them in prevention. So if someone has, let's say, congestive heart failure, they can follow up with them and so that they don't end up in the hospital again. So we reduce readmission to hospitals and we reduce repeated 911 activations. So the next slide, I think, will give us some examples. Next, please. So this is scenario number one. So an individual calls due to ear pain. They feel like it feels kind of like their last ear infection, but they don't have a primary care provider. So, and they don't have any transportation to get to the hospital or to a clinic. So they call 911. So what would happen now? What would happen now? Go ahead, Tueri.
It's actually Lauren who's doing it.
Oh, is it Lauren? Okay.
Yeah. Sorry, hence being awkward because I don't know them. Is this good?
Yes, thank you. Okay. So the current system would have the ambulance and fire department dispatched potentially, at least an ambulance, maybe both. And then the patient would be transported to a hospital emergency room. And as you could well imagine, they might not get seen for hours because people are coming in from car accidents with broken bones, things like that. So they get kind of pushed down in the priority list, and then they're billed for that transport and the emergency room service. Next piece, please, Lauren. But so what we envision is the call is triaged to telehealth or dispatch clinician, and the symptoms are assessed by a nurse or a doctor, and they can write a prescription right then and call it into the person's pharmacy. And also they can follow up with referral for primary care services and have that person enter a medical home. We want them to have wraparound services forever, not just for this one transport. And the patient never had to leave their home, and they didn't get transport or an emergency room bill. That's life-changing. Next, please. And then here's the second scenario. So 911 is called for an adult experiencing a behavioral health crisis. There doesn't seem to be any need for medical intervention. Nothing was ingested. They're not violent, so they don't need to be restrained. So what happens now? Next one, Lauren. So law enforcement often responds, an ambulance and possibly fire department. The individual might be placed on a 72-hour hold because they're not assessed for what is going on right then, and they're transported to John George or an emergency room, depending on situation in the system. And again, they're billed for transport and services at the destination facility. So what do we envision? Next one, Lauren. We envision telehealth or alternate specialized behavioral health response without law enforcement, or if it's questionable, we have a pilot program right now called Community Assessment, Treatment and Transport. Maybe law enforcement starts there, but then they're released. And now we can have a true behavioral health assessment and the use of the community health record to determine links to resources. And in fact, to find out if this person has been seeing a doctor, and we can get them into that actual office for them to see their provider. And they can explore alternatives to a 72-hour hold, because often those are not necessary. And then we also have the ability to refer for services or transport to crisis units or private behavioral health providers, clinics, things like that, depending on the situation. So there are a lot more options. Next slide, please.
Hey, Lori, this is Greg Hodge. Let me give you a little time check, because you're almost at time, and you will run out of time for questions. So I don't know if there's a way to accelerate some of this so you can get feedback that you may want.
Skip this one. Thanks, Greg. I appreciate that. Go ahead and skip this slide. Timelines. What's important right now is we're getting the community feedback right now. That's what's important. You can move on. And so if we don't have a lot of time for discussion today, that email address right there is your pathway to us. So okay. ems.redesign@acgov.org. So,
all right. So we have time for maybe one or two questions, because I know there's probably a lot that people have to answer. So let's take a couple questions now, and then obviously this is a ongoing conversation. So anybody any immediate questions or comments for Lori or for Anika?
Thank you for that presentation.
Go ahead.
Oh, go ahead, Greg. Go ahead.
No, go ahead. You got it.
Okay. Thank you for that. I think this is a conversation that community will definitely be interested in getting engaged in. So I guess one of the questions would be sort of what will be the process for community engagement across the county, I imagine, because there's just a lot of differences across the county in terms of the needs, as well as sort of there's the EMS part, and then there's the part that you're trying to get people into. So like assessing the capacity of that particular infrastructure, I think can be important. And then just one thing I wanted to flag is that I don't know if there's a opportunity for an alternative to the 911 being the point of entry, because that does tend to sometimes be a challenge in terms of getting behavioral health team resources deployed after the 911 calls, so that if there's can we have an 811? Can we have a 711? I don't know, but I know for a lot of our community, they're going to be avoiding the 911 call until sometimes that's the only call to make. And so sort of that intermediate piece, if there's any thought around, additional structures, I think that could support that.
Yeah, that's great. Thanks, Dr. Noha. It's good to see you. We do need to assess the capacity of the system for sure. So that will be part of this. And 988 is still something that's out there in the legislative world. So I suspect we're going to see more of that. And that will be the different avenue for mental health crisis. So we're all thinking about that. And, until we have 988, we want to get these people help. So if 988 isn't stood up by then, I suspect we will have both a mental health clinician and a medical clinician in dispatch. That's my vision.
One quick question I have around this is, and this is maybe something you can't answer tonight, in terms of the data associated with like how people come into an emergency room now. I'm not a clinician, so that's my disclaimer. I'm a lawyer. So, but the question I have is like, how many people come into an emergency room thinking it's something minor? And because they haven't had good primary care, some other more serious problem is discovered in that emergency room visit. So I'm just curious, what is your data telling you about that in terms of a teleconference triage, which might not pick up something like that ear infection might have been something more serious? That's the question. I'm asking in an inelegant way, but I think hopefully you get the question.
I do. Thank you. That is an excellent question. And if telehealth is involved, that means that a person is going to be holding that piece of technology for that person. So they will not use telehealth if they feel like it could be something more dramatic. And there are ways paramedics are very good at assessing what they call mimics and things like that, so that they know that, no, we really need to take you to the hospital. I know you don't want to. We do a lot of convincing in the field, I'm here to tell you. So we will, and the other thing that we do regularly is we do review of all of the patient care records when we do a new thing like this, and we would do the same thing. We would do 100% review of those particular calls.
Cool, thank you for that. Anybody got one last question before I turn this back over to Nestor for our closing? Anybody?
Hi, it's Dr. Donna. It's actually not a question, but again, a comment and saying kudos for working on this. I know that our paramedics have a lot of calls that are non-emergent, but I would just want to make sure that we still have some sort of clinical protocols in place so that those things that might be emergent or mimic things that could be emergent are still going to be cared for. And I just want to sort of keep in mind that we know that our Black and Brown patients are often underdiagnosed, and so how we're going to address that. But thank you for starting the conversation. Looking forward to continuing to dialogue.
And thank you for that. Excellent point.
Excellent. All right. So we did put the email emsredesign@acgov.org in there for folks who want to comment. And before I turn it over, just a point of personal privilege, I guess, I want to thank everybody for the work you've been doing all year. Thank you for all of the great effort and the good information that we get in these calls. And just from my family to yours, wishing you all a happy holiday season and look forward to the new year. So let me turn this over to my fabulous co-facilitator this evening, Nestor.
No, thanks, Greg. I think you're much better at sending us off with a warm, fuzzy feeling than I am. But I'll give it a shot. I hope folks found that last piece of our presentation helpful. This is our sort of attempt to move not necessarily beyond COVID, but there are other public health issues that we want to stay on top of, that we need community input, that we benefit when community is involved. So we're appreciative of you allowing us to have that space in this meeting. And if if this is something that you all want to continue doing, we can definitely take that into account for future meetings when we see each other again in 2022, believe it or not. So our next meeting will be, if I'm not mistaken, January 11th. I hope to see you all there. I hope everyone has a great happy holidays and that you all stay safe and sound. It was a pleasure to see you all again, and hopefully again in 2022. Have a good night, everyone.